You're watching Teaching Your Registrar about LGBTQIA plus inclusive healthcare, produced by GP Supervisors Australia and presented by Dr. Ruth McNair AM and Dr. Aziel Adan Sanchez. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
Thanks for coming, everyone. So this is to launch the LGBTIQ guide for supervisors, and these are all the authors of the guide. Great little crew. So it's myself and Aziel, Clara, Tuckmeng Su, who's a GP in Canberra, Mark Hughes, who's a professor and does a lot of work in LGBTIQ ageing, and Morgan Carpenter, who's an ethicist and intersex expert. Myself, I'm a GP academic, work in North Fitzroy in an inner city practice, as it happens with Aziel. I'm currently working part-time and doing some academic work as well, done lots of education training and research in LGBTIQ issues.
Thank you, Ruth. My name is Aziel. As Ruth mentioned, we work in practice in Fitzroy North. We see a lot of LGBTQI plus patients. And similar to Ruth, I'm currently part-time, also working at Melbourne Uni on LGBTIQ health, particularly in medical education, alongside a few other organizations.
So the guide, which is about to be launched after this, as you could imagine, it's a very big area, LGBTIQA plus health. So the guide is quite large. We've tried to cover off, I guess, the key information and knowledge about each of these subgroups, as well as a bit of an overview. So what we're going to do tonight is just introduce you to the topic, some of the reasons why you would want to talk to your registrar about this, and also perhaps give you a bit of some of the tips that come in the guide and show you some of the teaching activities as well. LGBTIQ patients have trouble finding trustworthy services. Unfortunately, we see lots of patients who still talk about these other things. They're worried they'll be judged for their sexuality or gender identity or sex characteristics. They're worried that they'll be misgendered, that people in the practice will use the wrong pronoun for them if they happen to be trans or non-binary. They're worried that the doctor they see won't know specific information about their health. And that's something hopefully this guide will really help with. If they're a young person in particular, they're really worried about confidentiality, as you might expect. So, I think this is something that's worth talking through and thinking about for your own practice. And, Ro Allen, some of you from Victoria might know of Ro. They've recently moved on from being the Commissioner for LGBTIQ communities to being Commissioner in the Equal Opportunity Commission. But they have been very strong advocate for inclusive practice in mainstream health services, including general practice. And they just say you shouldn't have to shop around for inclusive healthcare, which is so true. I think Aziel and I could vouch for the fact that we do see quite a number of patients that come to our inner northern suburbs Melbourne practice from lots of areas, and they probably pass 3, 4, 5 general practices on the way to see us. And hopefully what we're doing here is doing ourselves out of business. They should be able to go to any practice and get the same level of care. So the guide, we've given a little bit of time and space to the terminology. It's quite interesting. It's changing a lot as we speak. It's quite confusing. And I think that can sometimes bring us unstuck if we're not quite sure even what words we should be using. It's really hard to then delve into detail. So we've used the new ABS, or Australian Bureau of Statistics standard, that was produced last year. It was consulted on really heavily across the LGBTIQ communities. So it's got pretty good terminology and definitions. Basically, they cover off the 3 main areas. So diverse sexual identities, which can include all of these identities, including asexual. There's even a flag for asexual now. That's an important emerging subgroup. And also there's lots of other categories that don't quite fit in these main headings. Diverse gender identities, again, lots of new terms coming up, but I guess the big ones would be trans, non-binary, gender diverse, gender queer, and there's lots of others, as I said. Again, we have some specific flags out there at the moment that represent those groups. And then people with intersex variations. In some ways, it shouldn't fit in this LGBTQ acronym, in that people with intersex variations don't necessarily identify as being intersex. They literally just have an intersex variation. It's a bodily difference. And I've had quite a lot of discussion with intersex advocates around whether they should or shouldn't be included in the acronym. It's included because there are quite a number of overlapping issues, particularly around discrimination, around how people fit within their family of origin, around feeling marginalised. So for those overlapping issues, there's a sort of sense to it being included. While we can think about those three categories of sexual orientation, gender identity, and sex characteristics, actually there's a huge overlap. And this is data that came out of Private Lives 3, which is a big national LGBTIQ survey done in 2019. And that showed, let's just drill down to one subgroup. So let's say we're thinking of the cisgender women in that survey. So cisgender means women who are born women and still identify as women. So I'm a cisgender woman. So you can see the huge variety of sexual orientation that sample of women identified with. So less than half identified as lesbian. Some use the word gay instead for themselves. Almost a third identified as bisexual, and then smaller but important subgroups around queer, pansexual, and others. Let's flip over to a trans man in this survey. So that's a man who was born or assigned female at birth but identifies as male. In this sample anyway, you can see this, again, huge diversity in the sexual orientation in that group. So a few identify as gay, a few identify as bi. You can see in the trans group though, and non-binary, a lot more had these other sexual orientations around pansexual or queer. This is just really to step you through the fact that if you see, let's say, a man who says he's gay, we can't assume what his gender status is. If you see a non-binary person, we can't assume what his or her or their sexual orientation status is. And it's really about asking. So why do we think GP registrars should know about this? I think there's really two overall reasons. One is it's really just a holistic care approach. A lot of patients in this group want us to know about their sexual orientation or gender identity or sex characteristics, because they believe, and we also as GPs believe, that social context is important to the healthcare of our patients, that we need to understand that to really provide the best care we can. And then the second reason is around the really huge number of health disparities that this group experience, and that may be mental health, it may be physical health, it may be access to services. So we need to understand those differences for each of these subgroups and also be able to provide relevant and safe referrals for them. So I hope that makes sense of why we think this guide is really important. It's no longer okay to just say, oh, well, we don't need to know your sexual orientation, not relevant to me, let's move on. And just to define homophobia, biphobia, transphobia, so they're very negative attitudes towards people's sexual orientation and or gender identity that can result in violence as well. It depends on what you're looking at and which surveys and which area of Australia. I think if you are living in an inner city area in most of Australia, certainly things will have improved. If you're living in a rural, remote area, things may well have got worse for you as an LGBTIQ person. This is just a piece of data that we have to show what's happened over the last decade or so. So this is 4 surveys that have been done at La Trobe Uni of LGBTIQ young people up to the age of 25. It's very similar methodology, obviously different cohort, so it's a cross-sectional. But you can see here quite a big increase in verbal abuse directed at LGBTIQ young people from the 1998 survey through to the 2010 survey. And that was really concerning at that time. The most recent survey published last year, about the same. And you can see physical abuse also was increasing, and then in the most recent one dropped a bit. So the authors of this at this time in 2010 believed that this was about young people being more willing to come out younger, being more willing to be out at school, and therefore becoming targets of more abuse potentially. And I think this survey probably shows it was getting worse, and maybe now we're starting to level out a bit. But I also wanted to make the point that it's not equal within this whole set of subgroups. So if you're looking at the 2020 survey, so the overall percentage was 58% had experienced verbal abuse. Amongst the subgroups, the trans women and trans men in particular were much higher than that, and the non-binary were higher than the cisgender men or women. So I think also when you're looking at data around these groups, it's helpful to know who people are talking to as well as the context of the survey. This gives you a little bit of cross-sectional data that came out of the Victorian Population Health Survey. It was really quite a big study in that year, 33,000 Victorians. Interestingly, about 5.7% of that population-based study identified as LGBTIQ. And we think that's about the right percentage in terms of other international population-based studies as well of the population is this group. So you can see comparing the whole group of non-LGBTIQ at the bottom to LGBTIQ, you can see quite high, double the rates of discrimination, a lot more psychological distress, almost double the rates of depression, anxiety, and way more family violence than we ever anticipated in this group. This is just giving you some simple stats around what's happening at the moment. And again, in that survey, you can see differences across the subgroups. Non-LGBTI were 15%, whereas the trans and gender diverse were around 56% experiencing discrimination. And then this is the psychological distress data from private lives. So again, this is the cross-sectional convenience sample of LGBTIQ people. But you can see comparing the general population data here with the private lives 3 data, much higher proportion of people in the group had high or very high distress on the K10 scale. If you're just thinking about this one area of health disparities for LGBTIQ patients, this is, I guess, one of the most compelling reasons to know about someone's status, because if they're a non-binary person, for example, it just raises your awareness, have they been experiencing discrimination, whether it be at school or work or in the family? Is it something you need to directly ask about if they are presenting with, let's say, depression? It's very important. And the other big issue that's really problematic in our community at the moment is suicidality. Again, comparing the private lives data with population-based data, you can see this huge difference, 10 times the rates of the population-based studies experience suicidality. And again, this really relates to experiences of discrimination and marginalisation. And again, if we look at differences across gender, consistently, if we look at any data where we have enough numbers to divide according to gender identity, the trans and non-binary people generally have much worse health outcomes than the cis men and women. That's just a bit of background and sort of understanding the reason why you would want to understand these identity groups. So how to make your practice as inclusive as possible. And this is a whole of practice approach. So it's not just the clinical encounter, it's also the way people can feel in the waiting room, what receptionists are saying, what the paperwork looks like, and also the referrals at the other end. So we've got a teaching activity on this, just around collecting LGBTIQ data. So just asking your registrar to look at what's your intake form like in your practice. Does it include this group adequately? And how does the medical software capture those identity status? I know for sure Asiel and I use Genie, which is an unusual software in general practice, but it's pretty difficult to document a person's LGBTIQ status in the medical record. Mostly we have to free text it. And this is after a lot of lobbying to change it, particularly the gender identity.
So let's put a lot of those kind of figures into context and how it might actually impact not only the care that patients receive, but also how you might discuss these topics with a registrar. And someone who has been a registrar, not too long ago, it would have been absolutely valuable to have supervisors kind of talk through these topics and use it as a launching point to learn from one another. So we'll talk about Jamie, who is 19 years old, and with big thanks to Sarah Whitburn and Samantha Reed at Family Planning for developing these games. Jamie is 19 years old and is coming to your clinic. And, you've seen Jamie around in the past, and I think this is going to be increasingly common as trans and diverse people become more and more visible kind of within the community and become more and more comfortable disclosing their identity in healthcare settings. And when you're asking about Jamie's sexual history, he tells you that nobody has ever offered him a test before, despite being sexually active for now 3 years. He does disclose that he is a trans male, and he tells you that his family GP has not been best at kind of providing care and frequently misgendering him, which has led to decreased health-seeking behaviors and a little bit of hesitancy in engaging with care. I think what Jamie really allows us to do is to go through the experiences of someone who is trans and gender diverse and have a real world kind of look at every single step of the way and seeing how we can provide care and how we can improve on that healthcare delivery. So as a teaching activity, kind of walking my shoes kind of activity is so valuable, because it really does open your eyes to the degree of systemic discrimination that can sometimes happen inadvertently. It's not necessarily that perhaps GPs or health practitioners are being outwardly transphobic, But before even the patient can get through the door, there's already a few barriers that they have to kind of navigate and transverse, when all they want to do is just kind of walk in and receive care like absolutely everyone else. So a good kind of place to go through is, how would Jamie know that this is a clinic that is a safe space to disclose that they are trans, he's trans? The fact that he's already disclosed it has kind of signaled that you're doing something right. And this teaching activity provides a little bit more detail on what those kind of signals or factors could be, and a really great way for the registrar to kind of go through it all together. So some tips for inclusive practice. It really starts at the very, very beginning. Because again, you can lose the patient before they've even taken a step in your consult room, before you've even kind of had a chance to introduce yourself. The kind of healthcare spaces having clear signs that this is a safe space. So rainbow signs and posters, lanyards, posters that are around that show that this is going to be a space where we're at least thinking about the trans and gender diverse community and the LGBTQI plus community as a whole. Pronoun badges can also be a really good and easy way for the clinic to signal, hey, this is something that we're thinking about and at least actively kind of working on. And having a really clear non-discrimination statement somewhere along the way, either as the patient signs up or in their intake forms, is a really fantastic way of saying, hey, we're working towards making our practice safe and inclusive. Intake forms are always a source of vexation all across the board because it doesn't work very well, particularly for trans and gender diverse people. So I think that the really beautiful thing that we've got in general practice is that we don't have to go through all these hospital boards to change this one little thing on this one little form that will make the practice safer and more inclusive. It's relatively easy for GP practices to actually look at their intake processes and modify them as needed. So having a really good chance to look at what information you're asking, how you're recording it as per the teaching activity can be really valuable for both the registrar and the supervisor, as well as polishing some of those kind of communication. Once you've had the patient walking through the door, how are you actually going to make sure and back that up with safe and inclusive practice the whole way through? So some of the things that are recommended in the guide are, of course, using preferred name and gender all the way through, and preferred pronouns, making sure that that's documented appropriately somewhere on the file. Reassuring confidentiality and checking in again and again and again, particularly for a young person like Jamie, who might be very comfortable disclosing it to yourself or your registrar because they see someone who's safe and who they can trust, but they might not necessarily want their other specialists to know, or they might not actually want the rest of their family to know. So, the next of kin, getting very clear consent about who that data is shared with, I suppose. Have a really good feedback process for when something does go wrong, because of course, none of us can be perfect, to make sure that that patient also feels comfortable in giving you feedback and letting you learn from that experience. Some of these fabulous waiting room posters that you can access, and most of them for free. -18 has a lot of really, really great materials that you can pop all over your walls and make it look quite vibrant and welcoming. Same for Joy Bell, Gender Center, Trans Hub. There's a lot of really wonderful free resources that you can easily access online to signal again that this is a safe space. In terms of a non-discrimination statement, having it up front, having it really clear can signify to the patient that we're working on this particular topic and safe and inclusive practice. As a registrar, it might actually be good to kind of think about what are the sort of things that can go on a non-discrimination statement. Where can we put it in? Have a look at that systems-based approach before we even start to get to the communication side of things. And this is an example of the one that we use at Northside Clinic. And of course, backing that up with pronouns, making sure those are very clearly stated somewhere along the way on those medical files. And similarly, sexual orientation is another thing that we don't necessarily tend to ask about in our intake forms, but it just makes the rest of the process so much easier. Instead of having that awkward conversation around pronouns, it straight off from forms. And again, it just makes everything else a lot smoother. And in particular, it's also important to keep in mind the intersectionality in a lot of our communities. There's a lot of people who intersect between cultural and linguistically diverse communities and LGBTQIA plus communities. So making sure to capture some of those intersectional factors, because again, they might require either different resilience factors or different kind of approaches to how we manage the care. So this is one of the examples from the forms that we use at Northside Clinic. And probably the biggest thing that I would kind of highlight, and again, particularly for trans and diverse young people, is that their name might not actually match their Medicare details. And this is something, again, that can be quite tricky to navigate if you don't have the infrastructure around it. having a form, an intake form that allows you to right off the bat kind of disclose those details if they're comfortable will make that conversation a whole lot easier. So instead of having your patient constantly try to advocate for themselves and bring up the conversation and say, hey, actually, my name is not what it says on Medicare, or my gender is actually not what it says on Medicare, or my pronouns are different to perhaps what you might assume. Allowing for a really good intake process and a really good kind of robust intake form can make the whole conversation later down the track a lot smoother and a lot easier. So in the consultation, once we've got Jamie in through the door, what are some of the ways that we can demonstrate inclusive practice? Again, backing up all of those wonderful posters with some actual practical kind of clinical care. So in terms of asking and navigating those conversations, the guide provides some really good tips about how we can ask patients about their affirmed name and pronouns, making sure, again, that we reassure confidentiality the whole way through, clarifying those details between what's on Medicare and what's not, and making sure that that's documented all properly. And for the most part with my patients, I make sure I kind of break that all the way through with a new patient whenever I'm seeing them for the first time. We spend a bit of time just discussing all of those things right from the get-go. So the next clinician that they might see in the clinic, if it's not myself, has also all of that information really clearly documented. And as Ruth mentioned, we sometimes get a little bit creative with our software, but we always find some free text bit where we can kind of tack it on, or a notice somewhere kind of in the bottom where we can kind of tack it on. And again, it just makes such a huge, huge difference to care. Other aspects of inclusive language, getting used to gender neutral language, I think is good practice all around, not only for people who are trans or gender diverse, but for people in general. You might find that a lot of these skills certainly translate not only across sexual health with other communities, but also that sensitive communication, navigating confidentiality. All of these are really core skills that a registrar should feel confident with. In the guide, we provide some suggestions for what kind of gender neutral language you can use. But again, a really wonderful way of engaging your registrar with this and perhaps exploring it together if you're someone who's not as comfortable with transgender diverse health is discussing what inclusive language looks like, what gender neutral language looks like, particularly for a sexual history. What are the ways in which you can elicit those risk factors without having to kind of navigate really awkward questions? And for myself, I tend to kind of just put the menu out and say, we can do a throat swab, a vaginal swab, an anal swab. We can do some blood tests and kind of exploring the risk factors from there, rather than asking the very awkward, do you have vaginal sex or do you have anal sex, which can sometimes feel quite clunky. And so again, another wonderful way of exploring this with the registrars. The last thing that I kind of might pick up on there is sometimes pathology and radiology will gender people according to what's on Medicare. And this can certainly cause confusion if patients have affirmed their gender and present in a way that looks very different to what people would expect under Medicare. I've certainly had a few radiologists call me up and just confirm, what was the person's assigned gender at birth, just because they're trying to kind of work it out with the person that's in front of them. So talking about the ways in which that can impact care can also be very, very important. And the need for contraception, and particularly for a young person like Jamie, who's sexually active, I think we're really good at perhaps teasing out some of the risk factors and sometimes forget that contraception is still very much a thing that trans and diverse people require, even though they might be on hormone replacement therapy. So being comfortable navigating those discussions.
Without having spoken the language frequently, especially around non-binary patients and using they, them pronouns, it can feel really awkward. And then the patient's picking up that awkwardness and it's all, a bit tricky. But I think it's, most of my LGBTI patients just say, look, I'm fine with you asking me questions so long as it's asked in a way that's sensitive and you tell me why you're asking me that. Why do you need to know? And so I think that works really well.
So I'm really hoping that the guide will be able to provide some of those frameworks that you can kind of carry forward and actually provide an opportunity to upskill in this area as well. Again, transgender diverse people are just going to become more and more prevalent in general practice, regardless of where you are. We've got patients out in the middle of Mildura, so it's definitely something that's going to be relevant. So I think it is something that's going to slowly start to spread more and more into registrar training as that core element.
We've certainly had a registrar in our practice who was very conservative in their views. It made for a slightly challenging teaching experience because they were, as we all do, seeing a lot of LGBT patients and they were quite reluctant to talk about it initially because they just didn't know the language and they weren't particularly inclusive in their own thinking. So that was quite a challenging time for us to just try to help them through this, make it less uncomfortable for them. And in the end, I think they were very grateful, hopefully, that we'd helped introduce them to the whole topic without being judgmental about their attitudes either.
There's still quite a lot of just nebulousness about what trans and gender affirming care kind of looks like, including fertility and contraception. And again, I think a lot of GPs forget that trans people still have sexual partners and they can still get pregnant. And again, something that's not to be missed, as well as sexual health. So I might kind of leave off with this particular teaching activity around hormone treatment for gender affirmation and exploring the idea of the informed consent model. Thorne Harbour Health in particular has some really clear guidelines about what the informed consent model looks like, and just exploring the idea of a GP managing hormone replacement therapy for trans and intersex people. And again, certainly you might find different experiences and different degrees of comfort around it. So exploring those topics with your registrar can be eye-opening and a kind of a mutual learning experience for both.
For some particularly older lesbian women, for some trans people who have vagina and cervix, cervical screening and any vaginal exam can be really problematic or difficult for them. So there's some tips in the guide about how to make that experience a bit more comfortable for a trans person with a vagina and cervix, or for a lesbian bi woman, including acknowledging their barriers. For trans non-binary people, that there might be quite a lot of gender dysphoria around that body area. You know, they may not, as we've talked about already, use terminology like vagina and vulva. They might use other terms that feel more comfortable. So it's okay to ask specifically what terms they use for those body parts, and then use them yourself when you're talking to them. I mean, these are feminist principles in a way, but inviting them to bring a support person if they're having a vaginal exam or a cervical screen. We've talked about the gender neutral language, enabling control at the time of the examination, encouraging or helping them to insert the speculum themselves. And then for some, particularly trans people who are taking testosterone, they can have quite a lot of vaginal dryness as a result of the testosterone, which makes speculum exam even more difficult. So much like I do with my postmenopausal women with vaginal dryness, offering them vaginal estrogen therapy for 2 weeks before the speculum exam is really effective, and a lot of them are quite grateful for that. I think the other thing we mentioned briefly in the guide is around encouraging self-screening for cervical screening now for any people in this group who are underscreened. It can be a really useful way to get the cervical screen happening. I love this photo from the Cancer Council Victoria public cervix campaign a couple of years ago. So these are just a representation of people with the cervix who would benefit from these tips. We've got a teaching activity around the use of PrEP. Now that it's on the PBS, it's so much more accessible for trans, gay and bisexual men who are having sex with other men. So there are some questions around in the teaching activity for a registrar to think about when they're preparing themselves to provide PrEP. Do they have any ethical or moral concerns? So that, again, we're raising the idea that we can't all be 100% inclusive or understanding of this group. Worth a discussion, I think. Are there any contraindications? Would they use PrEP on demand rather than daily PrEP tablets? How much review should be done? And what would happen at the review? So this is all questions to be asked. And then there's a link to a really good resource from ASHM about the use of PrEP with older LGBT people, accessing affirming care, also home visits. You know, that's sometimes a really big point of concern for older LGBT people. You know, they've been quite closeted potentially in their younger lives, had a lot of potentially abuse and violence directed at them as younger trans or gay or lesbian people. And now that they're in their older age group, they're not necessarily comfortable with sharing their home with other people, particularly health providers. Sometimes they feel like they've got to de-gay the house before they have carers coming into their home, in case they do have experiences of negative attitudes. So, you know, that's worth some discussion with people. Obviously, some older LGBT people have grown up in the context of their sexuality in particular being criminalised. We have to remember it's only quite recently in Australian history, even the 1990s in Tasmania, when homosexuality was decriminalised. Families of choice is a really big one. So, you know, as you're probably aware, some families of origin reject their LGBT kids, and that's why LGBT people are way overrepresented in the homelessness population in Australia at the moment. This is still happening even now. So for some LGBT people, And actually, this applies even to people with intersex variations. For some of them, they've reported that families of origin can be quite negative around their intersex variation and quite discriminatory. So a lot of people in this situation have families of choice. So people that they regard as family who aren't necessarily genetically related, but are very important to them. And so that's something that can be really important, particularly amongst older people. Let's say if a partner dies, or if they're quite isolated, understanding who is in their family, who they might want to involve in their care making and decision making. Dementia care was a big one too. What happens to LGBT people if they are developing dementia? I've had terrible stories of, say, an older trans person whose family never quite agreed with them being trans, and then as they demented, the family came in and took over and started changing them back to their birth gender by changing their clothing or their name. So these things are really need quite a lot of advocacy. The Australian Human Rights Commission have produced a very important document around the care of people with intersex variations. And one of the key points there has been around the care of children, babies and young people, and the huge issue of unwanted or unneeded surgery for these infants soon after birth to try and correct intersex variations and make them look more male or more female. And in fact, the intersex community are advocating strongly for that surgery to be stopped until a young person is old enough to understand it and make decisions for themselves. Depathologizing is a really important part of this, and also the peer support aspects. So there's a lot to know about intersex variations, which never appeared in any of my medical education that I'm aware of. A lot of the issues for people with intersex variations don't really overlap with the LGBT area, but some of them do, particularly around stigma and discrimination, and importantly, family conflict. I think this is not an uncommon scenario to see an adult or a young person who's quite distressed about the surgeries they've experienced as young people.
But I think particularly with intersex variations, a lot of GPs kind of freak out and think that they have to know the ins and outs of that specific variation and kind of almost take over the specialist care. But in reality, the role that we have to play is very much as you would for any other kind of medical condition that might require an endocrinologist or a multidisciplinary team to really look after them. I think where the GP role can become quite valuable is in really practicing that human rights-based approach, that full informed consent-based approach, that depathologizing approach, and really encouraging, in the case of infants or young kids with their families, that familial kind of bond, and assuaging the parents that this is a normal variation. This is just another end of the human spectrum. It's not this huge kind of monster that we don't have to talk about and stigma. I think that's particularly where GPs can have a really, really wonderful role in bringing those kind of aspects together. And of course, for people who are a little bit further along or who may have had non-consensual surgeries in the past, working with them with their mental health, working with them through some of that medical trauma that might have happened, re-engaging them with care and making sure that you're advocating essentially for them as well. So this particular little case scenario is just something to get you thinking about some of those issues. And we're presenting with Eliza, who's a young mom presenting with a 6-week check. And there are some concerns around bilateral inguinal lump suspicious for undescended testes, potentially an underlying intersex variation. And Eliza's understandably feeling quite apprehensive and quite stressed and scared about how some future might kind of look like. Exploring again with yourself and your registrar, how you would address these patients' concerns, how you would have that empathic, again, human rights-based kind of approach. That is very important to underlying a lot of general practice overall. Thinking about some of the referral processes that you might institute. What are some of the specialists whom you might refer to, but also what are some of the mental health supports and counseling that you might kind of put in place, as well as some of the peer supports that are out there. I think something that's really clear that has come through a lot of Morgan's work and a lot of the work of intersex communities is that sense of isolation, like they're feeling like they're the only person with this intersex variation. And it's very hard to kind of visualize your future when you don't see yourself represented at all in any of the futures that you've kind of been portrayed out in society. So even having that peer connection can make someone feel more at home and more connected. And last but not least, considering how someone might support an adult who has undergone early surgical intervention and perhaps has had a lot of kind of medical trauma through that and is still processing some of that early treatment, I suppose, and the impacts that it might have ongoing. I think GPs are really well placed to kind of work with them to help them kind of re-engage in care and make sure that all of those concerns are addressed.
Thanks, Asiel. More and more LGBTIQ people are very interested in parenting and developing families in their relationships. The guide lists the many roles that we would have to support this area, including affirming their choices, of course, thinking about safe fertility options. I see lots of lesbian and bi women who have either a known donor or are seeking clinic donor sperm, and just talking through the safety issues around having a known donor and doing home insemination, advocating for them to get their donor to see a medical provider and get a full range of STI testing, sperm testing, etc., potentially genetic screening tests as well. Basically just transferring our knowledge from the heterosexual fertility that we do every day to the gay and lesbian, bisexual community as well. Increasing number of gay men and bi men who are seeking to be parents through surrogacy as well, which is very slowly becoming a bit more available in Australia. And then, the other role is really supporting parents and kids. And I mean, one of the big things that prospective parents talk to me about is their concern about whether their kids will be experiencing negative attitudes from peers and from teachers if people know that they have same-sex attracted parents or transgender diverse parents. So, there's quite a bit to be done there around supporting parents to help their kids become a bit resilient to these attitudes and knowing where to refer if this is happening to a family. And also being aware of the family violence issue that came up in that Victorian population health study. We know now there's slightly higher levels of family violence, regardless of gender of the couple. And that's something that we can sensitively uncover and work with people. Some research that I did with Drummond Street Services around preventing family violence in LGBTIQ parented families. And a lot of that came down to issues of community norms that really don't include LGBTIQ parents, the ideas of female or male role models and how important or not they are in families, and challenging the idea that biological parents are the ultimate aim or, the essential quality of good parents. But, celebrating the wide range of parenting styles that can happen, whether a person is biologically connected to that child or not. So, these are really steep learning curves for some of us, but helpful in helping our patients. There's this huge number of referral networks. I've just put an example here from the Victorian ones, but referral networks for GPs to use, and also peer support networks that we can refer our patients to as well. And some LGBTI specific services. For example, we've listed the AIDS councils in each state, which are now morphed beyond being AIDS councils to being LGBT and slightly now intersex health services. So in each state and territory, pretty much, apart from South Australia, I think, although Shine does a little bit of this, they're offering counselling services specifically for LGBTIQ people around mental health and around alcohol and drugs. Some of them have medical care, basically general practices. A lot of them, I think all of them, have peer education with trained peer support workers. They do a bit of outreach and health promotion. For example, there's a really nice FabJab team. They've just started doing COVID vaxes for LGBTIQ community specifically at the new Pride Centre in Victoria. This form of outreach and health promotion does need to be targeted to our community, I think, and in other services as well. So they're really useful for GPs to know and sort of get to know who your local LGBTIQ health services are and how to refer to them. If a registrar or indeed yourselves are interested in developing this further for your clinic, there's a couple of really accessible training options that are out there. A benchmarking exercise run by HWEI, the Health Wellbeing Equality Index, and Rainbow Tick. So they're out there, but they do take a while. These are our main key points. Encouraging discussion between you and your registrar about this group, thinking about how you're going to help facilitate disclosure from patients, trying to embed some of these inclusive practice tips in your practice, thinking about the specific health issues that are really helpful, including the privacy and confidentiality issues, which come up a lot urban or rural, but particularly in rural practices. Checking assumptions and not being afraid to ask as well. And then providing lots of good, what we might call safe and warm referrals to organisations that you have worked out are LGBTIQ inclusive.
It's okay to not know and not feel confident with this space.
Yeah.
And again, I think what the guide does really well is provide a lot of frameworks to explore this in a kind of more collaborative manner with your registrar as well. So don't feel like you have to be absolute experts to be able to engage in this topic.
Fantastic. Thank you both so very, very much. I'd like to point out we have provided the full guide for download. So anybody that is looking for information about definitions that you may have heard that you want to be able to refer back to, the other important thing is it's a big topic area. And so in terms of chunking this down, there's plenty of opportunities to do various activities rather than trying to get your registrar to digest the entire thing all in one go. Thank you both very much. Cheers.
Yeah. Thanks, Glenn.
Thank you.
Thanks, Asiel.
See
you.
Bye.
Bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervisors Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.